Perfect. Sounds good. Well, good evening, everyone, and happy Pride Month. Welcome to the annual Pride Month Journal Club. Thank you for joining us, whether you're here live or end up watching the recording at some point. We're going to go ahead and get started. My name is Aliya Feroe, co-chair of the Pride Ortho Research Committee, and I'll be moderating today's session along with my co-chair, Alicia Jacobson. And before we begin, just a few housekeeping notes. As we all know, please stay muted during the presentation unless you're speaking. Feel free to submit questions or comments in the chat anytime. We will give a quick summary about each of the three papers that we're going to be talking about tonight before launching into a more in-depth discussion. The key to this journal club tonight will definitely be participation. I mean, you all have brilliant ideas and we want to hear them. And then also this session is being recorded and will be shared afterward for those who couldn't attend live. So just to square things away, what is Pride Ortho? Pride Ortho is a community of proactive lesbian, gay, bisexual, transgender, queer individuals and their allies with a mission to provide mentorship, networking, and a sense of belonging for members of our orthopedic community. Perhaps more than ever, we all need to come together. And one of the various committees is the research committee, for which I'm lucky enough to co-chair along with Alicia. We're always working to advance our scientific work in this field and are striving to build collaborations across the country and world to unite over a shared research agenda. We were lucky enough to acquire one of the AOS idea grants this past year to fund three fantastic presenters for the first annual Pride Ortho Research Symposium during the annual meeting, and we only hope to build this in years to come. So just to get started on the evening, for which we promise to keep very timely, respectful of everyone's time, I want to review the agenda. We'll discuss three papers, starting off with a brief summary for those who did not get a chance to read the paper or just need a refresher, followed by a discussion. As I mentioned earlier, the more you participate, the more fantastic this event is going to be. So the first paper that we want to talk about tonight was Perception of Residency Program Diversity is associated with vulnerability to race and gender stereotype threat among minority and female orthopedic trainees by Reid et al. So just to provide a quick summary of this, as background, stereotype threat occurs when individuals fear confirming negative stereotypes about their identity group, leading to anxiety and underperformance. To assess how stereotype threat affects orthopedic trainees was the primary objective of this article. And they looked particularly at women and racial and ethnic minorities. Then they sought to kind of assess whether perceived program diversity might mitigate this threat. To do so, they issued a national survey of 1,127 U.S. orthopedic residents and fellows representing 40 programs across the country. They had a response rate of about 29%, 322 responded. Of those, 25% identified as female, 26% identified as underrepresented minorities in medicine. The survey assessed demographics, perception of program diversity, and stereotype threat via the Modified Stereotype Vulnerability Scale, or the SVS, to measure race and gender-based stereotype threat. So the SVS scores of greater than 15 per subscale were indicative of a high vulnerability to stereotype threat. And just kind of bird's eye view look at the key findings here. I mean, they found that women and underrepresented minority trainees had significantly higher stereotype vulnerability scores than their majority counterparts. Considering racial stereotype threats specifically, URM trainees had significantly higher race SVS scores than their white trainees. Black trainees in racially non-diverse programs had highest stereotype threat vulnerability, while white trainees in such programs had the lowest. In terms of gender stereotype threat, women had significantly higher gender SVS scores than men, regardless of perceived gender diversity in programs. And perceived diversity both racial and gender, was associated with lower stereotype threat scores among URM trainees, but had less mitigated effect for women trainees. So the authors concluded that stereotype threat is prevalent among female and minority orthopedic surgery trainees and is exacerbated by non-diverse environments. Enhancing program diversity and implementing strategies to mitigate stereotype threat could improve training experiences and performance. Kind of implications moving forward, with the residency program should consider institutional and individual level strategies, whether it's value affirmation, mentorship, diverse faculty recruitment, all to reduce stereotype threat and enhance trainee performance and well-being. So after that summary, just wanted now open the floor up to discussion. Thought something I just wanted to start off with would be, what might some of these limitations be of a survey of this kind, maybe based on the response rate of only 28%.
Well, so with that low of a response rate, I mean, it's hard to know if this survey is actually representative of like the greater population, and so definitely some sampling bias going on here. Additionally, I mean, when you have a survey like this that's optional, I mean, you're going to get some bias in the types of folks who are opting in to respond to a survey as well.
Absolutely. I mean, I don't I think 28% is still pretty darn good for, a survey study of this kind. It's tough to get much higher, but definitely the bias is real. Um, what were other kind of initial thoughts and critiques that folks had?
So something that, you know, Aliya and I have talked about specifically for this paper was the what kind of would have been interesting to take it a step further. And I think that, in our discussions kind of on the side, it seems like there are a lot of these types of studies that are survey based and that look at especially trainee experiences of diversity or their perception of diversity. And one thing we thought would have been interesting is to compare the perception of diversity with some of the objective markers, particularly around trainee demographics. And does the perception of diversity correlate or have any type of association with either the breakdown of a residency program by racial identity or ethnicity or gender identity, and how do these correlate and are there any differences? And something we actually got stuck on was how to do that, right? And how do you, on the one hand, protect your respondents' anonymity in the participation in this survey while also kind of gaining that kind of nuanced data. And that was kind of where we left our discussion around because we were a little bit stumped about the logistics of how you do that. I think on the one hand, it would be particularly interesting to see how that correlates, how your subjective and objective data correlate. But the way to protect kind of trainees' identity while getting that information was something that seems a little bit trickier. So I'm curious to hear if anyone has any other thoughts too about how we might do that, how to take some of this information, move it a step forward, but also protect kind of the anonymity of some of these trainees in the process.
Would the smaller sample size make that difficult too?
Yeah, for sure. And that was definitely something that we talked about, whether it's even they categorize region in some of their demographic criteria that they collect from their respondents. They're categorizing it by region rather than state or city. And I think, I mean, my assumption is that that was done to protect anonymity as well, but certainly a small sample size is going to make that even more challenging.
I've never done this kind of qualitative analysis research, like survey based. What is your all's advice for how to achieve larger sample sizes or try to eliminate some of the bias in the responses? Is there any way to do that? Because I get that you're kind of trying to eliminate it by doing the further analyses like you just talked about, by trying to see if there's correlation with other demographic areas. Um, but I wonder if there's something you can do from the get-go to get a larger sample size, which would hopefully give a wider range of responses to eliminate some biases. I don't know if you have thoughts on that.
Yeah, I mean, it's definitely a large predicament and a tough one. Just because, you want to cast the net wide, which I think the authors did, in surveying all the residents at these 40, sounds like 40 programs, so over 1,000 or over 1,100 residents. Um, I think, I mean, it's I guess it's tough to get a ton of buy-in from folks when you get survey fatigue. Program directors send out surveys all the time, and admittedly, I try to fill all of them out that I receive, but admittedly, some probably fall by the wayside too, just because residency is busy. So of course, like there's some kind of if folks feel like they have some skin in the game or like an incentive, certainly that would increase the yield. But I wouldn't want to necessarily cast the net kind of in a narrower field. I still think trying to get all 1,100, have that be the ultimate goal, I think should remain the goal. But yeah, I think that's always a tough challenge.
I think with survey-based studies too, 30 to 50% is is pretty good, and little under 30% with this one. But the point of that was raised about where people are submitting the surveys from, and like the regional aspect of it, you get the smaller your sample size, the more likely you are to identify those places. But I think, yeah, the incentive could help. What I thought was impressive was the distribution of across years. Right, they had pretty even numbers between all PGY 1 through 5, which was quite nice to see that. I'm curious if they were all from like similar programs, that like some classes, some residency programs were really compliant and others were not, you know what I mean?
Yeah, and moving off of that point, I think even now it would be interesting, just kind of thinking out loud here, I think it'd be interesting actually to see how even a residency class right now that has kind of, this is an interesting political climate that we're living in, and do younger residency classes that are starting now versus those that have started or 3 or 4 or 5 years into a residency have the perception of or a different perception of diversity, and how does the larger political landscape around discussions around diversity influence our perception of them, or our perception of our like individual level programs, maybe kind of an interesting thing to explore.
Yeah, I definitely love that point too, because I mean, I even wonder now that programs are trying to kind of scale. I mean, we had such a great push in kind of diversity efforts over the past, or diversity and inclusion efforts over the past few years. Um, I just wonder now that programs are trying to, or at least disguise their efforts now under different terminology and I'm just curious how we might kind of take a few steps back and how, yeah, the incoming, next few classes might feel or might perceive the program differently than, those that entered residency really in the kind of in the peak of, hopefully not just the only peak, but the kind of most modern peak of these diversity efforts.
I think as someone who's recently gone through the interview cycle period, one thing that I'm curious to see what happens to is the priority on diversity within interviews themselves. I think that really reflects a larger institutional culture, but also a larger acceptance across all of orthopedics around whether that's a priority. And, from my experience, diversity content to some degree was a huge portion of every interview that I attended. And so, I'm interested to see what happens to that, especially to Aliya's point around the, value. It's very clear that some institutions really care about it and will continue doing this work even if it has a different title. And I would
Yeah.
expect that not every program necessarily feels that way. Um, and so how might that shift in the next few years?
I mean, a question that sort of always comes to me with these survey-based studies too, are the is the big so what at the end of them, or like I guess what can we do with this data? What can we do next? Um, Certainly this is something that I've been chewing on with this paper in particular, but just wanted to see what other people thought about how can we how is this going to impact our practice or our further research, etc.
Does this sort of seem like a call to action for program directors, or who do you think that this would primarily target in order to change the sense of culture in these residency programs?
I'd probably say, and this is a call to action for program directors, but also there's so much kind of influence from residents themselves on kind of the priorities of a residency and the culture. Um, that it's a good and same thing as all the attendings at a program as well. So sort of a call to action to trainees and educators alike.
I also think that we talk a lot about allyship in respect to like the LGBTQ community. But I also know that like for me, even just talking with some of my co-residents who are non-white, and like hearing their stories and about their experiences being racially minoritized groups in orthopedics, it's stuff that we like me as a white person in ortho, it's stuff that I don't ever think about, stuff that I'm not even really aware of. I mean, just lots of microaggressions left and right for folks that don't fit that majority group in ortho. And so I think this paper also is kind of a call to action to the allies, whether that's the co-residents or residency leadership, just to be uh, supporting those minoritized groups in ortho and like using the privilege that we have as part of a majority group to uh, be calling out things, behavior that maybe would make somebody feel unsafe or unwelcome in a culture. And so, I mean, here, if we're on this call and we're part of the LGBTQ community, we maybe don't have as much experience being allies if we're in the in group. But here we're talking about potentially a different group that we might not be a part of, where we can practice and put into practice what it looks like to be a good ally.
I think it's a great point, Ezra, and also begins to touch on some of the elements of intersectionality too that I think are sort of a missed opportunity in this paper. And I wonder if that had the kind of elements of intersectionality kind of influence why we saw the results that we did in terms of like why gender-based stereotype vulnerability um, seem to persist even in programs with gender diversity, and could that be kind of some confounding with kind of racial stereotype threat or not? Um, but again, this comes back to Alicia's point too about just so we're trying to get increased granularity, increase be able to dive into some of those more nuanced questions, but I always have to be careful about anonymity and making sure everyone's still feels respected and private and that they still feel safe, of course, answering surveys like this.
Ezra, I'd like to respond to your comment about allyship. We had a webinar last week, but anyway, no. You know, I was struck by something written by Brene Brown. Those of you who've read her, I mean, she speaks a lot about vulnerability and the necessity of vulnerability to establish relationships. And she also brought up, and I don't know that it's originated with her, but that they're missing the fourth piece, which is really belonging. I mean, I've always heard DEI as, being invited to the party and asked to dance. But to me, that really doesn't mean that they wanted to dance with you. They were just being polite. Whereas I think belonging really gets into it of yeah, they wanted me at the party and I feel like I'm part of the group. And so for me, I'm working with Pride Ortho. I work with Ruth Jackson. I work with Nth Dimensions. I work with ALOS. And for me, just showing up is to tell people they belong. And so these kind of programs are great in this research, but ultimately it's what happens one-on-one or in smaller groups or locally, not in big organizations. And that's where it kind of has to happen one-on-one.
Yeah, thanks, Greg. I appreciate that commentary, and I think you definitely embody someone who is an ally on all fronts. So thank you for that.
Well, just in the interest of time, I think it would be worth now just moving on to the next article. It's certainly going to be a bit of a change of gears from now kind of looking at this big national survey-based study about residency programs, et cetera, to now we're going down into the micro basic science level. But Alicia, do you want to introduce this?
I will. Thank you. So, our next paper that we chose to discuss was entitled Functional Changes to Achilles Tendon and Enthesis in an adolescent mouse model of testosterone hormone therapy. And this was by Hold et al. And we're particularly excited because one of the senior authors, Dr. Megan Killian, is also on the call. And so hopefully she can shed some much needed light, especially on my own brain in particular, around the utility of how we can translate some of this data from mice models into the clinical realm. So just as some background, this paper was really focused on the influence of puberty blockers with testosterone, which is an important part of gender-affirming hormone therapy for transgender youth. And this is relevant in the musculoskeletal realm because connective tissue like tendon and enthesis are hormonally responsive. And so estrogen and testosterone are known to regulate, but really how the implications of this unfold, especially in the transgender and gender diverse community, are pretty understudied. And so this group chose to investigate how pubertal suppression and testosterone therapy affect Achilles tendon and enthesis during growth, so specifically in adolescent female mice. And so they used a mouse model with 4 different groups. The first was a control group. The second, puberty suppression alone. The third, puberty suppression followed by testosterone. And then finally, a testosterone only group. So the mice in that final group underwent puberty and then followed by testosterone therapy. And so what the group found was a couple primary takeaways. The first, in regards to tendon mechanics, that all groups with hormone therapy had an increased tendon load, that puberty suppression with or without testosterone increased the tendon's ability to respond to stress, and that there were no difference in tendon cross-sectional area, collagen organization or stiffness, or the linear modulus. They also found some histology kind of components that puberty suppression alone without testosterone did increase cell density at the enthesis, but there were no changes in collagen organization with any treatment. And so overall, what does this mean? So the authors took away that ultimately puberty suppression from this study, puberty suppression and testosterone therapy do not negatively affect tendon or enthesis structure and function, and potentially may even be protective to some degree as a part of gender-affirming care. So on to some discussion points. I think, as going through this paper and talking about it, one question I had, maybe Dr. Killian, you could start us off, are what are some of from your perspective, what are some of the benefits, particularly for this patient population, in using mice models to investigate some of these basic science questions? And then on the flip side, what are some of your primary limitations, and where can the data kind of not, what is the data not able to tell you really as you try and communicate this information to a number of your clinician colleagues?
Yeah, thanks. Thanks. Great introduction of this paper too. I really appreciate that. Um, so so this is my first time really talking about this paper, this work also, so bear with me. But I think uh the mouse model is really nice for basic science investigators because how the timing of events that are, focused on in this work, um, like it's great for a researcher in the lab and a graduate student who wants to graduate within a couple of years, right? So they're mice generally, female mice undergo puberty in their 3rd to 4th week of age. So we can really focus in on skeletal development and this really keen, like specific time of um, skeletal growth, rapid elongation of bones and tendons, but also this transition from like pre-pubertal to peripubertal to sexually mature. in a very short window of time. And so for us, we got these mice from Ariella Shikhanov's lab, who does a lot of work in reproductive biology, and she's been using this mouse model to study um, how gender-affirming hormone therapies impact or don't the reproductive health and potential for female-born patients. And so for us, we are using this model from people who are um, who are studying the reproductive side. So it's a really well validated model from a uh, reproductive biology, and it also um, focuses on this adolescent period of growth to kind of capture that puberty, that switch for puberty. And what I think is um, maybe it's a little bit tricky in the basic science space, is the way in which mice, female born mice, experience like period like menstruation and cycling. They don't menstruate, but their cycle is like a day or two long. So you're like, it depends on the hour and the timing of the day in which you um, uh, deliver these treatments that they're ovulating or not. And so that makes it really tricky from a basic science perspective, and that makes your window of capturing what you want to capture a little bit harder to do.
Mm.
What I think is cool though is that like you can really track over time in a really rapid period of time these changes to the musculoskeletal system too, as along with the reproductive system.
Yeah. Yeah, I think you're right that there's a lot of ability to fine tune and specify someone's or the regimens that each of the different groups are receiving. Whereas obviously you don't have as much control to do that on a clinical side. I think all of, even thinking about the first paper, all of our extensive conversation and discussion around anonymity is really not something that you have to protect against quite as significantly in a mouse model, which can also, the ethical side of components, also is diminished a little bit to some degree. Um, I have a couple questions about this. When you're thinking about does this, this population, the study is really focused on the adolescent mouse population. Do you think that you would hypothesize that this would extend, particularly since, most of our data suggests that patients are using hormone therapy long term? And how would you expect or anticipate this to translate to an adult population that either did or did not undergo puberty suppression in adolescence, but now is on, 20, 30, 40 plus years of testosterone therapy? Would you expect to see any changes that are maybe different from this adolescent group that we're looking at now?
Yeah, I think that's a really good question and an important point that um, in the context of uh, testosterone, the anabolic effects it has on the skeletal muscle inherently change how, for example, tendon and the bones are being loaded. And so long term, I would expect um, to see like similarly stronger um, tendons and bones in these mice. And there is some work from Dr. Shikhanov's lab that's exploring, after in the adult when you start uh, gender-affirming hormone therapies without the puberty suppression, what effects um, do these therapies have on, again, the reproductive system? But what's nice is for us in the orthopedic space, the limbs are just there and we can collect them and look at them. And so we're collecting these where we have paused, unfortunately, we have paused the work in this space, but we were collecting these mice carcasses that would otherwise get disposed of to analyze their skeletons. And so preliminarily we're seeing that yes, they're stronger. There's not a negative impact on the like the functional side of these tendons. I'm not sure, you know, globally what the effects are on the physiology of the animal, but from the tendons and the bones, they seem to be preliminarily a little bit more reinforced mechanically. But yeah, I
Yeah.
think that timing is important, and yeah, when you start the therapy, and the if you take a break or you come back to it, how that might affect. There's so many open questions in this space in
Mm.
orthopedics.
Yeah, and even how you add in the other components of aging as well. And so does some of the like does tea kind of offset potentially some natural effects of on tendon strength that individuals might see over the course of their lifetime just as a result of the natural aging process? And, how does that kind of look in terms of the overall injury profile? Yeah, I think that's an interesting question. And I think, maybe one last point for you. Obviously, the political climate has a really um, firm influence on what types of scientific questions we are or are not able to ask. And I'm curious from your perspective if you think there's a way to use basic science or mouse models kind of, we had mentioned earlier in our conversation tonight about ways of kind of circumventing the system and do we use different language and even as we're talking is relying or kind of emphasizing basic science or translational science a potential way to continue to explore some of these clinically relevant questions in a way that is maybe more amenable to funding? Or do you think that that's, obviously this is a really tenuous and sensitive topic, but I think, as for all of us on the call interested in these questions, but also interested in continuing the research, I think that's on my mind is how do we do this intelligently? How do we kind of continue to ask questions, but maybe just are we having to ask them in a different way?
Yeah, I think um, in a very open and frank way, I can say the way that this paper is published is different than how it was originally written
Mm.
to address some of those points that you're making. For my research group, we've never had funding in this space, but we had been talking with Dr. Shikanoff about ways in which to pursue that. And unfortunately, her NIH grants to fund this work were terminated before they were finished. And I think the way in which we communicate this work has been something we've talked about uh, without there's the value in getting the information out and sharing, you know, what we're finding and the importance of this work while also allowing it to get out. And I think that there's ways in which we may navigate the language to communicate what we want to communicate without it being um, doged, I guess. And I don't mean to say that in a political way, but there are like AI bots that are looking for words in papers and things like that. And so, um, yeah, I think that's the trickiest part for that um, that I have experienced with this particular work, but also just like knowing how not that's not the trickiest part, but it's a tricky part. And I think there's also the work that we've been getting started in and how do we see it through and how do we do that work without the financial support to do it or the like honestly the safety of being able to do it. So I think
Yeah,
that's yeah. I had a really great, oh, thanks, Lisa. I had a really great experience with this particular journal. that this was published in the connective tissue research. Um, the paper had been accepted with slightly different language, and the editors had allowed me to make changes in the proofs to reduce some of the risk. Mostly I was concerned about individuals who were authors on the paper and their likelihood to get federal jobs. And so, yeah.
Yeah. And I think it's an important, it's at least from my perspective, it's, as an author on a paper that we'll talk about next with um, a lot of words that you're probably referencing, but it's certainly a risk that we take on as researchers. I think the other risk that is on the forefront of my mind is for the patients that we are talking about. And so, I think there's a really high potential to manipulate data into whatever someone wants to interpret it to meaning. And so I think that's something that at least I think about quite a lot is, the purpose of our research, as a mentor once told me, is not to be right, but it's just to understand. And what happens, like, is, are we all understanding the same thing? Or are we taking away? And could that actually be detrimental to the patient population that we're actually trying to improve care for? And so that's something that at least I wrestle with and don't necessarily have a great answer to, but
Yeah, I think that's fair.
And I think Dr. Canada had a great question in the chat there too. I mean, is there a list of friendly journals, for research covering some of these topics on, sexual and gender minority health? And um, it's a great question and something that I need to really look into. And I'm sure kind of the landscape is changing kind of rapidly. I know from like an orthopedic focus, I would hope that that core specifically and Dr. Leopold stays open to topics of this kind, but I can't really speak to the others. And Dr. Canada, I see you've got a hand up there.
Uh, yes. Hi. I'll put my video on. Sorry, I just got back from being on call, so I'm just sitting, chilling and recovering. But I actually am helping someone who's not a member of Pride Ortho, but they did research in this area. And their article on gender-affirming hormone therapy and ankle fractures, I helped them revise. And I worked with my friends in through the Publications Committee of Association for Women Surgeons and asked them with a title like this, what journals we should submit to. So I will send you that list I just wanted you to know. And I think perhaps since we have things on our website for Pride Ortho, that this might be another thing. So
That would be great.
Yes, please. Yeah, definitely.
I'll send
Definitely
it. Who
send us
should I
that
send it
list.
to tonight when I finish?
Okay. Thank you, Dr. Canada.
Okay.
yeah, I think that's such a good idea of, kind of alongside the list of LGBTQI plus friendly residency programs, fellowship programs. I think this is just another part of that, how you continue to be academically productive in research questions that are interesting to the community, but actually how do you get them across the finish line? So I think that's a brilliant idea.
I think another place too that I've found like exploring, I mean, we have it's important to have our presence at orthopedic meetings and like that's critical and we have only have so much time to participate in conferences and things like that. But I've had really great and some of you may have done this as well, the anatomy meeting. There's an anatomy connected meeting and they have um in the last 4 years 3 years that I've gone, they've had really great content in in these kinds of topics, and it's a very inclusive environment for science and the journals associated with those with the anatomy. American Association for Anatomy is open to these. They're more on the basic science. There's anatomical record, which is more paleontology, and then there's like an educational one. But there's some like the community that exists at that meeting is really nice. And med school and anatomy focused.
Right. So I think in the interest of time, this has been a really interesting discussion. I think we're going to kind of continue probably a lot of the same lines of thinking with the next paper. So I'll give a little bit of introduction about what we were looking at here with this paper we did with a group at the University of Michigan. And so we were looking specifically at 5-year all-cause fracture rate for transgender and gender diverse adults using gender-affirming hormone therapy. And so we ended up conducting a retrospective cohort study using a US-based commercial claims insurance database. And we looked at this from 2009 through 2019 and included all adults in the registry or in the database who are between the ages of 18 and 65 with at least one diagnosis code for gender under the umbrella of gender identity disorder. And that was a lot of our methodology was actually used directly from our plastic surgery colleagues in the gender affirming surgery division. And so what we did was so we collected all fractures across all primary sites and then adjusted for age and comorbidities. And so what we found ultimately was that of a total group of about 10,000 adult patients, there were about 1,100 who were in our estrogen-based hormone therapy group, about 1,000 in the testosterone-based hormone therapy group, and then about 7,500 who we utilized as a control group who had a transgender or gender diverse marker in their chart, but had no prior history of hormone therapy use. And we also excluded patients who had any history of puberty suppression. And so what we found was ultimately that after adjusting for confounders, the group using the estrogen-based hormone therapy had the lowest hazard ratio, followed by testosterone, followed by the control, but none of them were statistically significant. And so ultimately, kind of similarly trending from our prior paper, found that hormone therapy was not associated with this clinical outcome that we were looking at. So that hormone therapy was not associated with an increased fracture risk over a 5-year period. Ultimately, this is somewhat reassuring evidence, but it was interesting in the context of some of the prior research. Obviously, there's not very much research on this particular topic. This was the first paper, to our knowledge, the first paper to look at this on this scale in the United States. And then the others were from a single center in Amsterdam, which actually found some slightly different findings that had some nuances. They also had a generally older population. So since I think it's kind of weird for me to ask myself questions on this paper, I think Aliya is gonna maybe take it away for a couple of
Yes,
questions.
Alicia, thank you. Now we can unleash all the harshest criticism so everyone can chime in. But no, I mean, I thought this paper was awesome. That's why I wanted to discuss it. It wasn't Alicia's idea to discuss her own paper. Um, and part of it was because it was not the findings I expected. I was a bit surprised that, that there was no significant increase in 5-year fracture rates. I don't know if it's due to, the extent of time that someone is on hormone therapy or the kind of, you need longer kind of follow-up rates. I don't quite know, but Alicia, why kind of from a generalizability standpoint, like how did you find or how might we think about how these, and again, considering it's like claims data, how these findings might be applicable to the broader transgender and gender diverse patients, and sort of those of that might not be captured under claims data, uninsured individuals. Um, kind of what the or those on other kind of gender affirming hormone therapy regimens? Like how do we think about them?
Yeah, for sure. So I will be the first to admit that this is an imperfect study at best. And one of the reasons for that, as you hinted at, is because we're using claims data, which has a lot of power in its size and scale, which was really the primary reason why we wanted to use that particular database. On the other hand, it leaves out a lot of detail. And at the end of the day, the trans and gender diverse patient population is incredibly diverse along a lot of different lines. One of them you mentioned, access to insurance status is certainly a primary concern for this particular patient population. And so because we were only using a commercially insured claims database, that excludes from the get-go a large population. So I think just like we would never take one paper and change our clinical practice, I think this is the same rule applies. I think the fact that we certainly wanted to provide some sort of data from the US, just because the only other data was coming out of a country that was socially quite different from ours. It's a very homogenous, the Netherlands is very homogenous. They have a very different level of social acceptance for trans and gender diverse patients. They have uniform health insurance, and as a result, all of their data is very, is kind of from the outside. I'm sure this isn't really how it is, but it looks very kind of neatly wrapped up into a bow. And so um, there's a lot more nuance that they can provide. Some of the interesting pieces to note here, this is a kind of, to be transparent, it's a bit of a slog to read this paper because there are a lot of sensitivity analyses that we included. But one of them that I think is important is that we changed, rather than looking at kind of a 5-year period, we did actually shorten that at one point to see if there's any difference. You'll notice that there's much smaller patient numbers or groups in the hormone therapy group. So the estrogen-based hormone therapy, testosterone-based hormone therapy only are about 1,000 patients were included versus 7,500. The reason for that is because we wanted to make sure that they had a baseline period, which is a standard protocol for claims data, to make sure that this was truly their first initiation of hormone therapy. But by doing that, we automatically excluded vastly more patients using hormone therapy, presumably because as soon as they get insurance, it's a much more common practice to start hormone therapy right away. And so there were many fewer who had in the database at least, had that window of time, so we couldn't look at it. So whether this is a true representation even is kind of an interesting thing. As we started to reduce some of those statistical kind of confinements that we added to increase the rigor of the paper, we started to see that actually a lot of this data became statistically significant in the direction that we kind of see here. But obviously the methodology we chose was for a reason, to make it valid. So even repeating this study, in 5 or 10 years to look at kind of longer term may be interesting as well to see if it holds up.
Yeah, I mean, for sure. I think it would be super interesting to see kind of where this goes from here and what kind of follow-up or the longer follow-up might show us. I was also curious, Alicia, with was there an opportunity with the claims data to stratify based on like fragility fractures versus standard traumatic fractures, high energy versus low energy, or using claims data that's kind of isolated some of those osteoporotic defining fractures or diagnoses, like vertebral compression fractures or kind of distal radius fractures in the low energy setting. Did you have could you have been able to stratify in this way, or like how might that have been helpful?
Yeah, so it would have been very helpful. We talked about this extensively, and ultimately decided to move away from it for a couple of reasons. The first, we did ultimately in our data retrieval tried to collect that, but there weren't enough outcomes of interest to protect patients' identity or anonymity rather within the database. The outcomes were just too small. And so then it wouldn't, we weren't able to kind of provide any valid data or conclusions. The other piece is that the methodology that we were trying to use also didn't really allow us to tailor to be really sure that we were actually capturing fragility fractures versus traumatic fractures that someone may otherwise weren't sure. Kind of in summary, we weren't really sure that the fractures we were going to collect were actually truly fragility fractures, and two, the ones when we tried to do that couldn't really get enough outcomes to provide any valuable kind of takeaways or while protecting someone's anonymity. So that was it's always a question that comes up. I think I believe we listed it within our limitations in this paper, and certainly something to investigate in the future.
Definitely. I appreciate it's again kind of going back to the sensitivity of these patient populations and making sure that we respect anonymity and given that sometimes there's low numbers. So that makes sense. It'll be interesting as these databases grow to be able to look at some of more of that granular data. I'm looking at the time, and we are nearing our promised end time. I said I was going to respect that. So I just want to thank you all again for a great discussion. I think we just generated like 100 new research questions for us to now pursue. So it's time to get to work. Um, if you'd like to kind of join forces and pursue any of these, shoot us an email. Otherwise, kind of a few additional closing reminders. We'll share the recording on the webpage, kind of just to revisit some of the discussions that we had. And then also want to put in a plug. I see Kayla put in this plug too, that Pride Ortho is hosting another Pride Month event next Tuesday, webinar and coming out in Ortho. It's going to be fantastic. I already know it. So hope to see you all there. Thank you again.